Perfect. So I have four aliquots for us today. They're going to get successively smaller. So the first one is going to be HPI and some past history. So this is a 20-something-year-old female. She presented to the hospital via EMS after having a seizure. The initial history I acquired actually came from the patient's partner who was with the patient leading up to admission. So they stated that she was in a regular, relatively normal state of health until the morning prior to hospitalization. That morning, she began to feel generally unwell, and she subsequently vomited once. She, however, proceeded with her day plans. She actually took a boating outing during the daytime. After returning that evening, she had an additional episode of vomiting, and she continued to feel unwell. So that night, she then had her first lifetime seizure, after which EMS was called. They found her diaphoretic, clammy, hypertensive, tremulous. The partner did not report preceding fevers or chills, headache, cough, sore throat, chest pain, abdominal pain, dysuria, or other symptoms. However, per EMS notes, I just saw this in the chart en route, she did describe severe headache and substernal chest pain radiating to her clavicles. So just some very brief chart review I did before I met her. I just noted that she had severe myocarditis confirmed by MRI earlier this year, or rather that year. That had been complicated by cardiogenic shock, actually, but her EF had subsequently recovered. And interestingly, no etiology had been identified for that episode. And at hospitalization, she also had right occipital and right posterior cerebellar ischemic strokes that were attributed to cardioembolic etiology given her myocarditis. For residual deficits, she just had a small visual field cut. She had no surgical history or allergies, and she was taking Wellbutrin and sertraline. And it's the end of Big Aliquot 1. I'll put this in the chat so that we can get this all on the board here.
All right. This is a really, really rich and exciting place to start, Andrew. Thank you again for bringing yet another what is bound to be phenomenal case, and then also laying it out like this. I think there's a couple ways that I think we could go about parsing this problem. One of the ways is that we can say that we are going to just use the diagnostic label of a seizure with true clarity and true certainty coming into this case, and say we are going to deploy sort of our schema for a new onset seizure and our sort of management playbook for that problem. Another way to do it is to say, this is somebody who's coming in with a diagnostic label of a seizure episode, but we're not 100% certain that this indeed was a seizure itself. For me, because I have been fooled so many times by thinking that somebody has had a seizure and finding out that they had a different transient neurologic syndrome, I'm going to sort of adapt the idea of a labeled seizure to say that this is somebody who had a transient neurologic syndrome that was characterized by what sounds like some shaking head movements and preceded by some vomiting, chest pain, and headache as well. And so then if we then enter into the space of transient neurologic syndromes that can manifest that way, seizure is one of them. And there's also three other S's that we can consider here. The things that can oftentimes mimic a seizure include things like syncopal episodes, which can very frequently be accompanied by convulsive episodes. We can have strokes and TIAs that can also manifest occasionally as seizure episodes. And then also episodes of hypoglycemia or sugar problems that can sometimes manifest with syndromes of shakiness, convulsions, changes in one's consciousness, and then also sometimes other features like diaphoresis and autonomic symptoms. And if we look at the description of this individual's event, right, we see many of the features that could accompany all of those four S's, right? Syncope, seizure, stroke, and sugar or hypoglycemic episodes. And so while the sort of predominant diagnostic weight is saying, let's just go down the seizure pathway, that's tempered by the reality that these transient neurologic syndromes or these transient loss of consciousness events can have a huge, huge overlap. And so we're going to hold all of them in some degree of equal probability until a few things happen. One, we see another episode with our eyes and recognize that this was indeed a seizure or a syncopal episode. We measure something that tells us the answer here, or we find some other confirmatory test, for example, an MRI that shows a new stroke. And so I think that I share this just really to outline that the label of a seizure, while it can be very compelling because it is a known and defined space, oftentimes has to be held against these other three S's, and we usually work them up in parallel falsifying certain hypotheses and proving certain hypotheses along the way. Charmaine, what are your thoughts here?
Oh, that was so good, Jack. I couldn't agree more. So what I'm going to do is just kind of look at the other aspects of her presentation and kind of see how that informs this episode of loss of consciousness she's had. So there are two aspects of it, right? Like, the vomiting episodes and the feeling of unwell that she was feeling prior to this episode, and then the background history that is quite significant. So in terms of like episode of like fatigue or vomiting, how can that contribute to a loss of consciousness? Is it a symptom? For example, like increased ICP leading to some nausea, vomiting, or is there some electrolyte derangement with vomiting? If she's like becoming have more electrolyte imbalances that decrease the seizure threshold. Because one thing we know from her past history, she had strokes, and that strokes can over time become foci of seizures. So then the question becomes like, did anything else lower that seizure threshold, whether that be like medications, acute illnesses, electrolyte imbalances? So that is one hypothesis. The other one that we should think about in someone who has significant cardiac history, like quite unfortunate to have idiopathic myocarditis with so many complications. I'm glad she is doing better from that regards. However, with that, in terms of like strokes leading to decreased seizure threshold, the other thing to consider is that the myocarditis itself, and if there is any scarring that has happened that can lead to focus of arrhythmias. So are we dealing with an arrhythmogenic cause, like whether, like ictal syncope being one, but like bradycardias or ventricular tachycardias in someone with like a background of myocarditis? So something else to consider. So I really like Jack's approach of like kind of zooming out and labeling this a loss of consciousness. And within that, thinking about seizure, thinking about syncope as well, and all the etiologies that goes within it. Any other things? Oh yeah, he's also like Wellbutrin. So thinking about like medications that can also affect your seizure threshold. Jack, any other thoughts?
No, I think the only other piece that I think sometimes come up is that some of these tests that we ultimately need to distinguish between the two of them take some time to come back, right? Like it can feel a little bit unrealistic to be like, okay, we're going to wait 3 hours for the MRI to decide which pathway we're potentially in here. And so then the two sort of features that are usually present initially on arrival that we can use is sort of the pre, intra, and post event, right? Each of these different things, seizure, strokes, syncope episodes, and hypoglycemia, some of them give clues that they are coming, like a seizure manifesting as an aura, syncopal symptoms manifesting as pre-syncopal symptoms, or a stroke and a TIA that can manifest with focal neurologic deficits. They all can have a lot of similarities in terms of the actual event themselves, but if there is head turning one way and rhythmic convulsions of an event, that can heavily influence seizure as opposed to just shaking episodes, which can be found in seizure or syncope. If there's profound autonomic dysfunction during the event, like again, profound diaphoresis, that might push the needle towards a hypoglycemic episode. And then also some of them leave different traces. For example, the trace that's left behind after a seizure episode can include things like an elevated lactate, an elevated CK, a post-ictal state, and maybe tongue biting. But some things that we commonly may use, like urinary incontinence, for example, that can be shared across seizure, syncope, and many of these things. So it's really things like tongue biting and the post-ictal state that can help drastically increase the probability of a seizure episode, and then also things like profound autonomic dysfunction along with the neurologic changes that could signal a hypoglycemic episode. And if someone comes right afterwards, then you're likely not dealing with a seizure and should prioritize something like syncope. And then if there's focal symptoms, obviously the probability of a stroke goes up a ton.
Beautiful. I have some answers for you, Jack and Charmaine. So I'll give you kind of a blanket initial labs presentation for her now. So down in the ED, she was afebrile. She had rates of 110 to 120s, blood pressures of 160s over 110s, and she was saturating fine on room air. For her exam, she was actually quite postictal, so I can't get any history, hence getting the history from her partner. I didn't appreciate any crackles on her exam. Otherwise, her exam was fairly unremarkable, just she was quite postictal. So her initial lab showed a bicarb of 15, an anion gap of 22, with a lactate of 14.2, a creatinine of 0.64, a calcium of 10.7 with an albumin of 5.6, a T-billy of 1.5 with a D-billy of 0.2. Leukocytosis to 13.9. There was no funky differential on that. No thrombocytosis. She had a negative lipase, and her initial high sensitivity trope was undetectable, and her EKG was normal, sinus tachycardia. However, in the ED, she then has another episode of seizure, and they kind of repeat some of this workup. And an EKG was kind of similar. It showed some ventricular bigeminy and some mildly increased T wave size, but nothing else concerning for ischemia. Her tropes then increased to 463, so we have cardiology come down, and she has a new Takotsubo pattern on her hearts compared to a prior echo, and her EF is 40 to 45%. Initial blood cultures and RVP testing are negative, and then she gets the stat CTA, chest, head, neck. It shows no large vessel occlusion. She did, however, have non-specific hypoattenuation in the right parietal and right cerebellar lobes. And that's the end of aliquot number 2.
Wow, what a whirlwind. Thanks so much, Andrew. So, even from the first sentence that Andrew said for her being post-ictal, as Jack beautifully laid out, that just increases our pretest probability that this was a seizure. And, although like having this patient had another seizure episode is not great, in terms of a diagnostic purposes is quite helpful because you're witnessing the events for yourself. So you can see in terms of the cardiac etiology, what it's doing. She's in a hospital, so we can give her some Ativan, keep her safe. So now we know we're dealing with a seizure episode. And then the question becomes, why? And the other things that is like supportive of that, lactate of 14. One thing that for sure can cause your lactate to go that up is a seizure episodes. Thinking about like all of your muscles that are working incredibly hard and switch to anaerobic, and your lactate goes up really fast, and it actually clears pretty fast afterwards once you stop, once the seizure is over as well. So I'm not quite worried about that anion gap yet, but that lactate bears repeating and then following up to make sure there's nothing within that gap that is not explained by the seizure itself. And then I will just comment on the ECG and then pass the mic to Jack for more discussion. In terms of like the Takotsubo, so Takotsubo can mirror kind of left main proximal LAD disease on ECG. So Takotsubo tends to be one of our new misdiagnoses. Often is because of that. And with Takotsubo, like any like stressful situation can lead into a Takotsubo pathophysiology. However, how much of it is the seizure? We know like the association with like seizure, just the increased metabolic demand on the body and cardiovascular. So the question becomes, is this like hyperacute in the setting of this episode of seizure, or is there something else going on that has led to the Takotsubo cardiomyopathy? Jack, what are your thoughts?
I love it. I think I love so much the pearls on the connection between Takotsubo and seizure. I think that is just brilliant. I think, I guess just to sort of share, I don't know that this is not a problem space that I have like narrated or thought through out loud very often. So rather than like being able to sort of go through a like very predefined schema, I'll just sort of think about the ways that I'm sort of bringing some of these pieces of information together. And like you said, right, like we've made progress in moving from transient loss of consciousness framework to the seizure episode for all the reasons that you mentioned. There's a post-ictal state, there's a profound lactate episode, and that sounds like again, we can sort of say that we are in the bucket of seizure now. And so then the question becomes, this is a new onset seizure in somebody without a known diagnosis of epilepsy. And I think I sort of think about things that can cause a new seizure in 3 buckets. The first, which is a bucket of exclusion, is that this is a new diagnosis of epilepsy. The second is that there is something acutely systemic happening, so some sort of toxic or metabolic disturbance that is leading to the development of a seizure, or there has been something that's acutely injuring or activating the brain, and that's causing a seizure, right? The new diagnosis of epilepsy, we're going to get to that by virtue of evaluating for bucket 2 and 3. And if we think about the things in the second bucket, right, what are the toxic metabolic disturbances that could cause seizure episodes? Many of them are things that we can find either from the history or things that we can find from the laboratory data. For example, things like profound hypoglycemia, that can cause a seizure. Profound hyperglycemia, that can cause a seizure. Low sodium, high sodium, low calcium, low mag, uremia. There's all kinds of, right? Any of the metabolic disturbances that can cause altered mental status, if they get severe enough, can also go on to cause a seizure. But we don't necessarily see any signature of those things on her lab. It doesn't sound like she's profoundly hyper or hypoglycemic. We don't see severe hypo or hypernatremia, and no big metabolic abnormalities. One hypothesis for the seizure or for the very, very high lactate and the high anion gap is that this is from the seizure itself. I'm sort of holding in the back of my head, but not necessarily bringing it into the fold that there was potentially an ingestion that could drive a very high lactic acidosis. But again, if the lactate doesn't rapidly clear, which we usually expect to see, and if the anion gap doesn't close pretty quickly, which we usually see after seizure episodes, we might entertain a toxic ingestion with a little bit more certainty here. So that's bucket 2, right? Not a really strong, compelling case, but maybe something to pull into it. But then bucket 3, I think, becomes quite compelling based off of the CTA findings. And really, again, any acute injury to the brain can lead to the seizure, right? And this could be things like ischemic events, hemorrhagic events, thrombotic events, like not in the arterial system, but actually in the venous system. We can have things like PRES related to underlying hypertension, or I should say not related to, but that oftentimes comes with underlying hypertension. And then we can also have inflammatory disease states like meningitis or encephalitis that can also cause seizure. So anything that can acutely irritate the brain, whether that's bleeding or clotting or inflammation, can also trigger a seizure. And so I think if we look to from that bucket and say, where are we likely to make the most progress? It's probably in bucket 3, given the abnormal imaging findings that we have with this new hypoattenuation. A CTA can allow us to make some progress, but an MRI is going to allow us to make much, much more progress. And we'll be able to better characterize, are we seeing signs of a recent stroke? Are we seeing signs of encephalitis? Are we seeing complications of old strokes like encephalomalacia in that area, which could become a nidus for seizure episodes? Many individuals who have a prior stroke may end up developing a new focus for seizures down the road as the brain undergoes structural changes in response to that prior stroke episode. And so really, I think what the information that we have here tells us is that we probably we are very likely dealing with a seizure. And of the 3 things that can cause seizures, or of the 2 buckets that can cause secondary seizures, toxic metabolic or acute injuries to the brain, we're likely dealing with an acute injury to the brain. And a clearer window into what that acute injury etiology could be is going to be an MRI, which again will help us say, is this a vascular phenomenon like bleeding or clotting, or is this an inflammatory phenomenon like a meningoencephalitis? And I think once we can better characterize that, we'll be able to make much more progress in terms of the next steps for where we go.
I love that, Jack, so much. The one thing that I would add is that kind of investigating that med list on Wellbutrin a little bit more, because a baseline is associated with seizures as well. So if she has any increased dose, like increased treatment dose, or again, like just to be comprehensive, is that like overdose with Wellbutrin is also associated with seizures. And the third way is that, whatever is going on, that Wellbutrin can decrease the seizure threshold. So that's a medication that I would hold and investigate a little bit more why the patient is taking it, and if there have been any recent changes to that.
Beautiful. So to answer some mixed questions, on quick chart review, the only other significant medical history you see is like anxiety and depression, for which she takes the Wellbutrin and the sertraline, like she sees a counselor quite a bit. And then I asked a lot about ingestions. There's definitely no funky ingestions, anything like this. Other than the boating trip, wasn't in the woods or had no interesting exposures, was on the beach, but was wearing shoes. So number three, by the way, when I asked that question, I was on like the telephone and my residents made fun of me when I was like, "You're on the beach recently?" They were like, "It's pretty normal." I felt like an ID doctor there. Okay, so aliquot number three, she had a MRI showing new subacute infarct in the right PCA territory. Per neurology, this would have occurred prior to her hospitalization. We still pursued an LP. I believe this actually occurred prior to the MRI. It showed only one nucleated cell, no hemorrhage. The protein was elevated to 80.7. Glucose was normal at 67. And HSV, VZV, West Nile, and enterovirus and Lyme testing were all negative in the CSF. So by this time, the patient is no longer postictal and she can provide more history. Regarding unexplained symptoms, she stated that she really doesn't have much. She just has intermittent severe headaches. I transfer her from the step-down unit where I was taking care of her to the floor with a diagnosis of provoked seizure from acute gastroenteritis plus Wellbutrin usage plus new stroke. However, I learned 24 hours later of additional workup that's pursued by the neurology team that actually ultimately leads to a correct diagnosis. And this is the end of aliquot number three.
All right. Interesting, interesting. I'm very excited to learn where the neurology team went with this one, because I think honestly, Andrew, your working hypothesis maps on exactly to sort of where I was what I was thinking about when you relayed this information. As Charmaine was saying, like, it's totally compatible for somebody who's had prior strokes with these sort of multifocal resolving infarcts. It's totally compatible for that person who's on a medication that is lowering their seizure threshold to potentially develop provoked seizures in the setting of those prior infarcts, as well as any sort of acute illness. So we have to ask ourselves, knowing that that's not the diagnosis there, what are some potential routes that we may be able to explore that could give us a clue here? And I think one question that oftentimes comes up is what exactly makes for a non-inflammatory lumbar puncture, right? A lot of times we say that a white blood cell count that's normal tells us that there's not CNS inflammation. And I think that that is a totally reasonable heuristic to go off of if the type of inflammation that we're looking for is underlying infectious etiologies. But many non-infectious inflammatory neurologic diseases could potentially have normal white counts, normal glucose levels, but a slightly elevated protein level. And a protein level here of around 80 to me, and again, I could be way off on this, but it strikes me as a little bit higher than I would normally expect. I usually think about protein levels being somewhere around the 40s to the 50s. And so seeing a protein in the 80s makes me wonder, is that a clue that there could be underlying non-infectious inflammation happening in this individual CSF? And non-infectious inflammation can come from, again, systemic inflammatory diseases like systemic autoimmune diseases or paraneoplastic diseases that then manifest in the CNS, or primary inflammatory CNS diseases that can manifest in the CNS, whether that is an antibody-mediated process or another autoimmune-mediated process. For example, something like acute disseminated encephalomyelitis, which you can see in the post-viral phase for individuals who have had recent GI illnesses. And so Charmaine, I'm super curious to hear your thoughts here, but I would wonder if the protein is the thread that's worth pulling on, and start to look for things like oligoclonal bands and an IgG index to see, oh, maybe there is more inflammation. But beyond that, I feel like I would sort of be at a loss and shooting in the dark without the help of the neurologists.
No, I think like that is a very good thing to anchor on. And, thank God for neurologists, especially with like intracranial processes. And if there's like a primary CNS vascularity that is going on, or are there any primary neurological disorders that is like, just presenting as recurrent strokes or and possible seizures. I think like, I think about usually the wall of the vessels to be involved in the scenarios. She's like 20 years, so common etiology like atherosclerotic disease. Again, less likely, however, like, getting a good family history here, and also kind of getting your lipid panel, maybe sure she doesn't have any of those issues. And you don't necessarily see, I think the imaging that she's got, I don't know if she got a CTA. So at least like, we know, she doesn't have any carotid disease, for example, that at older age tends to be a common reason for cardioembolic stroke. And the other things that I usually just kind of pull out, and while like, I defer to our neurologists to investigate, the LP and like help us better characterize that. So kind of pulling this screen back and think about, okay, what are systemic etiologies that we shouldn't miss, as also like me being a medicine doctor. And I usually think in a young stroke, I think about like coagulopathies, like especially like APLS, is a good thing to think about in this patient who was presenting at the young age with recurrent strokes. The other things like, PFOs, if she has a DVT with a PFO. And then the other one to consider is like, atrial myxomas of some sort. I know she got an echo. However, I wonder if this is, a TEE would be better able to characterize like if she has any clots there, any atrial myxoma that is also flickering while we're investigating this specific CNS causes as well. And any etiology of like vasospasms can also lead to stroke in younger folks. In addition to kind of vasculopathies that we already talked about. So kind of thinking about, if I'm thinking about a schema, is that, stroke in a young patients, like hemorrhagic causes, trauma and stuff, she doesn't really fit in that category. And then for ischemic, it would be like kind of luminal causes. And then like thinking about the vessels, the walls of the vessels itself. And so those are the things that I would also like want to investigate a little bit more in addition to the elevated protein you mentioned.
All right. Ready for the final aliquot? Okay.
Always.
Okay. So basically neurology was thinking along both of your lines of thinking with the elevated protein, which is completely over my head. I didn't even consider that. And given the prior strokes in the new stroke, they actually pursued DSA testing of her CNS vasculature. And that showed multiple areas throughout the ACA, MCA, and PCA territories of concentric stenosis in series with dilation, consistent with some sort of vasculopathy, as all the radiology reads as. And then for a rheumatologic workup, she had negative ANA, ANCA, MPOPR3, SSA, SSB, RF and CCP, HIV, syphilis, CMV, IgG, and IgM. The ESR was normal. Someone asked about that. Cryos were negative. She had a little bit of a low C3 at 71, but a normal C4. And a full thrombophilia panel was negative, and it was really a full thrombophilia panel. I checked it all out. And then just it's not in the it's not written down by the scribe right now, Aya. But just to go back, because this is really key and I don't want this missed for the final diagnosis, is I just want to emphasize again, because neurology basically asked about this history like doggedly so. She does have a history of intermittent headaches. I'll just say that.
All right. The one thing that I was like wondering with the stenosis, I think moya moya is one thing to think about. It's usually like, the circle of villus, I think like the arteries from that, any of them that has like vasculopathies, and those patients also, a lot of them have like cardiac disease as well. So that's something that came to my mind, although that is the extent of my knowledge about moya, if anybody wants to contribute to that. And the other thing then with recurrent headaches to think about with like that elevated BPs, like I think press that you mentioned, Jack, I think is a really good a thought as well. So I wish I could say the recurrent headaches is, I feel like that is a clue that I'm missing. So Jack, what are your thoughts?
No, I mean, this is such a, it almost feels a little bit silly to even as a general internist to even be like pretending to play in the sandbox. But for the sake of the discussion, I will share the amount that I can potentially that I may be able to about this space. And I think, the space that it seems like we're in, I completely agree with you, Tremaine. It's like, this is what seems like a CNS vasculopathy in a young person who has this sort of history of headaches and new seizures. Like all of the things that I think we've seen so far can potentially be explained by the presence of this vasculopathy, like the strokes and then the seizures and things that come from that. And you listed several of the CNS vasculopathies that I can also list. Like in the acute phase, there's things like PRES, and then also something called RCVS, or reversible cerebral vasoconstriction syndrome. And then like the other things is like these sort of bizarre entities that I have only read about occasionally, but never seen a real case of, things like Moya disease, like you mentioned, which is not a good one for my stutter, and then a bunch of weird acronyms like CADE and CADASIL, as well as some other ones that I'm sure I'm missing. I only know this from reading a prior NEJM case where this came up, but most individuals who do have CADASIL have a history of migraine with auras, and so that is oftentimes the initial manifestation, and then they go on to develop all of these other symptoms like acute CNS episodes, psychiatric disturbances, and frequent strokes, and then they can be found to have this non-inflammatory vascular disease on the MRI. So by virtue of that, of not having a better guess, I would be curious about that, but I think you have to probably exclude the acute common things like PRES and RCVS, and then look into that sort of like less non-acute space, because it seems like this has been something that has happening for some period of time. And distinguishing between those diseases, Moya, CADE, CADASIL, and stuff, I would feel very, very limited in being able to do. But that's one association that I have learned about before, is that the migraine with auras can be a feature of CADASIL, but it may also be a feature of many of the other ones. And that's just a knowledge gap for me overall. So that's really reaching into the doldrums there, but I'm curious to learn.
CADASIL is such a great thought. CADASIL is absolutely such a great thought. And I think with CADASIL tend to run in families. So if she also has family history of a stroke, especially young family members, I think that's another clue. That was fantastic, Jack. Thanks. All right, Andrew. Yes.
All right. Yeah, of course. I don't know how much I have to teach. Jack, there was a very big sandbox that involved neurosurgery, rheumatology, infectious diseases. I think one other service that I can't remember. So it really was a multidisciplinary discussion to figure out actually what next steps to take in this patient, because it really wasn't completely clear. There was a discussion of maybe doing a biopsy, but they felt the yield of that would be pretty low and it was too high risk, so they didn't do that. They did do MRAs of basically all the large vessels, like in her chest and her abdomen, and they did an MRI of her heart that was all negative. So everything was isolated up to the head. So they discharged her really with not a clear answer, but now we think we have an answer in the outpatient setting. So what they did is they stopped her sertraline with concern that that may be precipitating RCVS in her, as SSRIs are a common trigger of RCVS in patients with this disease. And they start her on verapamil. So I saw that she saw neurology about 6 months later. And ever since, she's not had any headaches and she's not had any strokes or anything like this. And then on additional history, that in the neurology note, they just comment that she had a lot of like kind of brain fog and difficulty concentrating, which it's hard to tie that to the disease, but it may be related to RCVS. But the working diagnosis is that she actually has a diagnosis of RCVS. She had been on the sertraline prior to the old hospitalization too. I think the key to this was realizing that the stroke was not an endpoint diagnosis. Figuring out why she had the strokes was key. I definitely didn't have that triggered. I think part of that was because when she had the myocarditis, we kind of had a good presumed diagnosis of cardioembolism. But if you remove that and you look at it in the frame of how you two did, she had multiple strokes as a young woman, which I didn't frame it that way, then it becomes much easier to kind of go down that path. But I'll just take your thoughts there. I think it's still not 100% solid, but it seems this is what the diagnosis is.
I trust you all. I mean, I think it's from the little that I know about it, it's plausible. I think, one of the things that I think is super interesting about this, about RCVS, is the fact that the vascular abnormalities, I think, are reversible. So theoretically, like if I think, but again, I could 100% be wrong here, that if we were to re-image her after this, you may see changes in the underlying vascular abnormalities. I think that that's like the reversible nature of the disease. So that could be something that could ultimately be confirmatory of the diagnosis. But I think like syndromically, things things totally fit with that. I had no idea about the association between SSRIs and RCBS. That is super, super interesting. But I think the symptoms there of like headache episodes and vascular episodes with those imaging findings seems like it makes a ton of sense there. So yeah, I mean, it sounds like there was a really, really smart, brilliant team involved here, and like what a fantastic case to get to learn from, and so fun to get to think through this with everyone here. And Charmaine, props to you. Neurophobia is not going to catch us today.
This is such a fantastic learning phase. Thank you so much, Andrew. We thought about medications, but I think Wellbutrin got most of our attention and not so much SSRI. Another plug, always, when in doubt, just like look through all the medications and their side effects. It's just always amazing to me that the side effect of medication that can unmask, make underlying diseases a lot worse. And yeah, I agree with you, Andrew. It seems like a great working diagnosis. The one question, like in my mind, I think for the RCVS, usually the LPs tend to be normal or only have like mild elevation in protein. So it was interesting that she had such elevation in her protein. I wonder if like that is like also worth repeating just to make sure normalize, or was it related to like the post-stroke or something like that. Well, such a fascinating case. I have a lot more to read and learn about.
Same here. Thank you both for discussing again. Beautiful discussion.
So fun. Learned a ton. I'm so more than anything, I'm so happy to hear she's doing well and she has been free of these symptoms. And kudos to everyone who made this happen for her.
Yeah, thank you so much, Andrew. That was just a blast. And yeah, I'm amazed at the cases that you're getting to see, and just so grateful for you bringing them to us. I feel like, it's to be able to practice thinking through somewhat familiar spaces, but also discover the edges of one's knowledge base and be like, okay, like there is much more reading and learning to be done, is like such a gift, and feels like such a wonderful space to get to be in. And this is, 2 weeks now that you've facilitated this for us, and I just feel incredibly grateful for that. It's so fun to practice and to discover the boundaries so that we can expand them a little bit more week to week. So this was just awesome. And now I will turn it over to Yasmin to again continue to expand and refine our knowledge gaps here in this case with what looks like some brilliantly organized teaching points.
Oh yeah, before that, it's just like random things are coming to my mind. And I think the reason why they kept asking about the headaches was because it's associated with thunderclap headaches, right? Okay, yeah. It's like slowly coming back to me. All right, Yasmin, take us away. I will stop talking.
No, amazing discussion. Honestly, listening to you discussing this great case, thank you, Dr. Andrew, has made me try to keep up and read about these other syndromes that I was not very aware, but thank you. So in our teaching points, the approach to seizures, we have to discern between the seizure or mimics of the seizures, such as syncope, strokes, TIAs, and episodes of hypoglycemia that can manifest with shakiness and convulsions. And we can even wait to witness an episode and determine the presence of lateral tongue biting, gaze deviation, and such signs. Also, this patient had myocarditis that can present with scarring of the cardiac tissue, and one of the arrhythmias that can cause is ventricular extrasystoles with palpitations or syncope. So we had to keep that in mind too. The medications that can affect the seizure threshold, as this patient is taking Wellbutrin, is propion, antipsychotics, lithium, MAO inhibitors, theophylline, azathioprine, and so on. And again, for the differential diagnosis of seizures, we can look at those 3 buckets that Dr. Jack gave us of things that can trigger seizures, like toxic disturbances or metabolic disturbances, acute brain injuries, or reach the diagnosis to exclusion. In the labs, we can look for profound hypo or hyperglycemia, low sodium, low calcium, or any acute injury brain, such as ischemia, hemorrhagic, thrombotic, inflammatory, can trigger a seizure in patients. And also, if the patient has faced treatment with any type of drugs, we have to also determine if there was a change in doses, if there's adherence, if they added something to the treatment. And then jumping to the lumbar puncture, this patient had an elevated protein, which make us think about a non-infectious inflammation and think first about malignancy or primary inflammatory diseases such as autoimmune. Dr. Sharmin said that in a young patient with coagulation or thrombotic issues, we can suspect APL. And then we jump to this like rather obscure diagnosis such as moya moya or CADASIL, which present both with stenosis and occlusion of the vessels, or CADASIL that, since it's an inherited diagnosis, we can investigate if anybody else in the family has it. We reached this, Dr. Andrew and his team reached the diagnosis of RCV syndrome, which is a transient cerebral vascular spasm that presents with recurrent thunderclap headaches and recovers within 3 months. And these are all the teaching points for today. Thank you again. I definitely have a lot to read today. Back to you, Dr. Jack and Dr. Sharmin.
You and me both, Yasmin. You and me both. Thank you so much. That was awesome. Thank you all so much for joining us. It's just always, we learned so much. This is the best community. We're really lucky to be part of it. Thanks, Jack. Thank you, Andrew. Thanks, everybody. Really appreciate you. Have a wonderful rest of your day, and we'll see you tomorrow.